Good morning. Good morning. Welcome to the full Health and Human Services Committee meeting. Your chair, Delegate Rodney Willett here. Great to have so many folks with us this morning. We are still on our information gathering tour here as we get presentations from the administration. And we've got several today that I'm really excited about. We're going to start with DMAS. And want to welcome back a familiar face and a new face, but really not a new face. We have Jeff Lenardi with us, who is on his way out, but he's been so helpful, appeared here multiple times with us. And Jeff, I want to thank you for all you've done for DMAS for the state. Really appreciate that. And then the new face that's not a new face, Steve Ford, who is now with us. Steve has spent plenty of time in this room. He knows all of us, and I couldn't be more delighted than to have him in his leadership role there. Now it's a tough job, but if anyone's up for it, he is, and I'm really excited to have him in that role. So we'll start there, and then we're going to hear after that from the Health Commissioner Cameron Webb from VDH. But we'll start with DMAS and let you guys present, and we may have a question or two for you, but we'll be easy on the new guy. Okay.
Good morning, Mr. Chairman, members of the committee. Really excited to be here today to talk to you about the various initiatives underway at DMAS. I am going to do a brief introduction of myself, and then I'm going to turn it to Jeff and his team of experts who have been working on this. I'm in day 4 at this moment, so at the very beginning of day 4 at this moment. So I'm going to turn it to the experts so that you can actually hear what's going on and get good information as opposed to from me. But I did want to just really briefly introduce myself to those of you who don't know me. My name's Steve Ford. I'm the new director. I started my career almost 32 years in the state of Virginia, almost 32 years ago, upstairs in the previous iteration of this building for JLARC. And I've worked ever since in or around Virginia state government. And for the last, the vast majority of that period, it's been in healthcare and specifically Medicaid. I am more than ecstatic to be back at DMAS. I'm really excited about it. A lot of challenges, but I'm excited about it. I'm excited to work with the administration, the secretary, our sister agencies, you all in the General Assembly, and then there's a litany of other external and internal stakeholders that we're all working together with to really support the goal of making these programs that we work on the best they can be under the constraints that sometimes are put on them, but the best it can be under those constraints for the folks who really need the services that we all provide. So I look forward to developing a strong relationship with this committee. To that end, if there's anything you all need, please reach out to us and we'll attempt to provide that. And with that, unless you have questions for me specifically, I'll turn it over to Jeff to get into the meat of the program because I know we have a limited amount of time.
Thank you, Steve. That's great. Maybe we'll let Jeff come up and then we'll get both of you back if we need to on the question side. Well, come on up. Thanks.
Good morning, Mr. Chairman, members of the committee. A little disappointed, not even a token question for Steve, but it's fine. It's fine. I'll defer to him when I get the questions. So we were asked to come and I think do a lot. We will try to touch on a lot of things in 25 minutes or so, I think is what we were allotted. I think primarily what we want to talk about are sort of an update on some key components of implementing the HR 1 or One Big Beautiful Bill that as it's called from last summer, because there's a lot going on that's due that needs to go live this coming fall. But then we were asked to talk a little bit about what else is happening in Medicaid over the next 2 to 3 years. And there is quite a bit, both on the programmatic and policy side, but also there's a lot of operational change that I just want to make you all aware of. Because as you work with us on new initiatives, new policies, a lot of times, we provide technical assistance, but there will also be, I think, some discussions in the coming years of whether, not just if we can do something, but when, because of some of those operational changes. So just want to frame that out for you. And again, happy to take questions as we go. Oh, there we go. Okay, start very quickly with an overview, particularly we've got some relatively new members of the committee. This is Our current Medicaid population, as of just a few days ago, March 1st, 1.8 million Virginians. It's down from a peak of 2.2 during the public health emergency. I think the only thing I'll highlight here, the vast majority of those are low-income children and adults. You see about 600,000 children there in the top left. And then if you add up the parents that are in that base bucket there on the left, the light blue, as well as the Medicaid expansion, which is all the adult population, we serve well over 650,000 adults. So that's the core of our population, and they get sort of, most of them, a traditional health insurance plan that Medicaid covers. However, we do have a smaller number of individuals with disabilities and older adults, and they make up a smaller portion of who we cover, but do consume the vast majority of our services. They are higher need, more vulnerable, and we'll talk about sort of the services they get in just a minute. So here's what they cover, and I try to frame this in sort of two ways. Medicaid, for those low-income families and children, it's a traditional health insurance program. It's what you all may have if you're under COVID care. It provides hospital, physician, prescription drugs, some behavioral health services, dental. We cover vision for kids. It's not covered for adults in Virginia's Medicaid program, but you can think about it as a health insurance plan. But that's only a part of what Medicaid does. So Medicaid is the biggest payer for long-term care in the country. Virginia is no different. Cover about 2/3 of the nursing home bed days in Virginia every year, and then cover a lot of what we call home and community-based services for individuals who have that level of need. They are sort of functionally eligible or need the nursing facility level of care, but are able to be supported in their home and in their community. So a lot of personal care assistance for them, activities of daily living. We also have the three big waivers we call them waivers because that's the policy mechanism of CMS, but these are programs for individuals with intellectual and developmental disabilities. So there's a broader suite of community-based services to support those individuals and their families. And then Medicaid covers a bunch of services that are sort of unique to Medicaid. Early intervention, there's something called PACE, which is sort of an all-inclusive or sort of one-stop shop where individuals get all of their care when they're elderly, when they're available. Non-emergency transportation, that's something that it's not completely unique to Medicaid, but by and large, it's not something you get in your traditional health insurance program. But transportation is a big barrier to care for a lot of Medicaid individuals, so non-emergency transportation, rides to and from the doctor, something that Medicaid covers. Last slide here on the background. I always like to touch on this. And this is, again, Medicaid's a federal-state partnership, so we need direction from you all and from the governor on what we do, but then CMS has to approve everything that we want to do as well. Yes, it is challenging sometimes to navigate the need for those dual authorities. I'll be the first to admit that, but it is the price that we pay for having the federal government pick up more than half of the cost of our program. So for base Medicaid, which is the majority of the folks, they pay about half of it. For Medicaid expansion, however, they pick up 90%, and the 10% state share is covered by a assessment on Virginia's private acute care hospitals, and so there's actually no general fund impact there. So net across the program, the federal government pays for about 2/3 of every dollar that Virginia spends in Medicaid, and so we do have to get their permission before we implement new initiatives. All right, I'm going to move on to HR 1. So we have talked earlier this session specifically about the eligibility provisions in HR 1, and I will update you on our progress there. But we did want to just zoom out and make sure that there's a wide enough lens on everything that's in that piece of federal legislation and what DMAS is doing to implement that, because I know you've heard a lot about these over the last 6 to 9 months. The Spanberg administration has really brought the key individuals together across state government and sort of aligned on these three goals. And again, not just in the eligibility space, but when they look at implementing HR 1 sort of in a Virginia-specific way that protects Virginians who rely on these services, these are those overarching goals or that framework. And number one, making sure that those who are eligible stay enrolled and maintain their coverage, and that these changes do not lead to unnecessary churn or folks losing coverage even though they're still eligible. That's really, really critical. We want to be efficient, we want to be effective, and we also want to implement these programs in a sustainable way, because we have to operate under the assumption that these policies will be around for a while. And then really critically important is not just implementing the requirements and being compliant, but making sure we're leveraging this to connect individuals with the resources they need for education, for workforce development, and to sort of bolster their economic mobility. Just a snapshot slide you've seen before. I think when I'm going to talk about these provisions, they do sort of fall into a few buckets, but the two I'll highlight. Eligibility requirements, it's not just the work requirement piece. There's a few other eligibility components I'll have a slide on, just so you're aware of those. But then changes to state financing. So we talked about that federal share. The primary change that's going to impact Virginia, you've heard about it, is the federal government is limiting the extent to which states can tax providers and then leverage that as a financing mechanism to increase the federal reimbursement that we receive for those providers. And so the primary way that that's going to impact Virginia is on our major provider assessment on our private acute care hospitals, which supports both Medicaid expansion, but as well as supplemental payments to improve the rates that they receive through Medicaid. So this is a timeline of everything that's in H.R. 1. I will not go through every section and every policy. I want to use this, while it's not to scale, I want to use it to orient you to where we are currently. So as we sit here in March of 2026, the first three flags there have passed. We're in between the November 5th, 25 red flag there on the bottom and the October 1, 26 light blue flag there at the top. So those first three we have moved past. We've submitted our Rural Health Transformation Grant. We've received that award. We expect that all of that funding will be actually formally released by CMS in the next week or so, and the administration's off and running with key stakeholders, trying to move that forward as fast, as quickly and as prudently as we can. Those next two blue flags on the top, the October 126 and the January 127, that is the lion's share of the eligibility work that we're going to talk about. So that is really the sprint that DMAS and DSS and the administration are doing over the next 9 months to make sure we're operationally ready, again, not just for compliance, but to support the members who are subject to these requirements, that they get the resources and the supports that they need. When you look into 27 and 28, that's when those provider assessment provisions are going to come into place, and when we'll start to see reduced federal funding for our hospitals. Okay, I am going to dive in on, I have about one slide on the major eligibility changes. You have seen these before, and so I will focus more on sort of what the operational impacts are and what we have to do over the next 9 months in order to implement these. So first, it made some changes to categories of individuals who are not U.S. citizens, but who are currently eligible for full Medicaid. Starting October 1st, 2026, some of those individuals may no longer be eligible for full benefit Medicaid. There's a list of about a dozen very specific non-citizen categories who are currently eligible. Most of them, other than three that you see here, the legal permanent residents, the Cuban Haitian entrants, and those from the Compact of Free Association individuals, which, for those of you who didn't look it up yesterday, that's the Marshall Islands, the Federated States of Micronesia, and Palau. But those individuals will still be eligible for full benefit Medicaid. Those who do not fall into one of those three categories, and our current estimates, as you see there, is this is going to be more, at least as many as 7,500. First thing we have to do is we have to redetermine them. So they're not automatically disenrolled. We have to give them a full redetermination to make sure they are not eligible in a different category, that their immigration status hasn't changed, that some circumstance isn't making them eligible for full benefit Medicaid. Once we go through that process, anyone who is not eligible for full benefit Medicaid, we'll keep them enrolled under what we call our emergency Medicaid program. So this is a federally authorized program that covers a narrower set of emergency services for individuals who otherwise would be eligible for Medicaid, but for their citizenship status. Okay, also effective January 127, so about 9 months. It's a reduction in what we call retroactive coverage periods. So current policy, if I applied for Medicaid today, but I had health insurance costs in the prior 3 months, I can apply for that retroactive coverage period. And if I'm eligible for that, Medicaid can pay for those costs. So we do see this a lot. Folks maybe be uninsured. They come to Medicaid when they have a medical need. And so this retroactive covered period covers that. I'll also say it can function almost as a catastrophic plan, even for middle income individuals, because it's called medically needy spend down. So if you have sort of a major health incident, and you get a bill for $100,000, $150,000, you spend that down to the point where it sort of impoverishes you, then Medicaid, kicks in. And so I think the message here is it shortens from 3 months to 2 months for some and 1 month for others. I think the key message here, and you'll see this throughout the HR1 implementations, is communicating so that individuals know this. And the key message here for your constituents is make them aware and don't wait. If they have if they're uninsured or underinsured and they have a big medical need and they're anticipating a big bill, don't wait to get the bill. Apply for Medicaid, and then you can work through that process while everything is working itself through the billing system. Reduction in duplicate enrollment. This is really sort of what I consider a cleanup effort. There are individuals who move between states, and so they may be enrolled in 2 Medicaid programs at the same time right now. This is an issue that's been going on in Medicaid probably since 1965, and there already are processes in place. There's one federal database that sends a data file to all states regularly, and we have a process to work that. What HR1 does is it adds a data point. The federal government's going to be sending some additional data that they're doing some matching on to states, and then it's requiring states to take a bit of a more proactive approach in terms of how they take action on those cases. And so we've got to have that up and running by the end of this year as well. But again, the goal there is to get the person enrolled just in one place. So they do still have health coverage where they need it, but just have them disenrolled in the state where they no longer live. All right, now we're going to get into, I think, what are the most substantive and operationally challenging components of the HR1 eligibility determinations, eligibility rules, and the ones that are going to have the most significant member impact. So this one, starting January 1, 2027, everyone in the Medicaid expansion category, so if you go back to the slide with the 3 circles, so there's everybody, all the adults there on the right-hand side, about 550,000 of them, they will have to recertify or go through the renewal process to ensure that they're still eligible every 6 months. Currently, they do it annually, so this doubles that for them. I think the key thing here is certainly there's some nuts and bolts systems changes that we've got to do. The system automatically notifies the member and the eligibility worker when they're up for renewal, and it also tries to determine if they're still eligible without anyone touching that case. We call that ex parte. So the system goes out and it pings all the data sources we have. And if they verify they're still eligible, no one has to touch it. They just continue their eligibility. A letter is sent to the member that says, congrats, you're still eligible, and everybody moves on. But for those where the system cannot definitively determine that they're still eligible, that's where work has to happen, and that's where the individual has to get a notice. They have to respond to that notice, and then a worker on the state or the local side has to take some action on that case to maintain that enrollment. So that increased workload and that abrasion both on the consumer side and on the staff side is something that we want to be planning very, very carefully for, again, so that we don't get into a situation where individuals are losing coverage even if they're still eligible. So again, you can see here really what's been going on. Primarily, it's systems changes, policy changes, but also planning for communications so that people know this is coming, and then coordinating very, very closely between DMAS and DSS, as DSS owns the eligibility determination system for Medicaid and other benefit programs. So layered on top of that, so that expansion group all has to go through renewals every 6 months. Part of that renewal process will now include these new provisions on work and community engagement requirements. This is sort of the snapshot policy slide. Again, you've seen this before. The rule is 80 hours per month of education, work, volunteering, other community engagement. On the right-hand side, you see exemptions. So there's about 550,000 people in Medicaid expansion. A good chunk of them will be exempt in one of these categories here: pregnant, postpartum, special needs, individuals, American Indians, and Alaska Natives. And then there are also some categories that the state has some flexibility in terms of implementing those exemptions. And so we are awaiting final guidance from CMS, but we are not waiting to make preliminary decisions. We are often running and sort of crafting the state's policies to be as sort of Virginia-friendly as possible. And then obviously we'll have to adjust if any of those policies are not allowed when final guidance comes out. But we don't have the luxury of waiting for that final guidance. This is sort of the operational strategy slide. And again, this is something that the teams have been working on going back to the summer. And it's really, I think, kicked up in earnest, certainly in the last 3 or 4 months, as we've had to get down to defining system requirements, sketching out communication plans, and then as we've been collaborating with the new governor's administration and leadership at DSS. Number one, and this goes back to that overarching principle of maintain coverage for eligible individuals, is we want to automate as much as humanly possible. We want to automate those exemptions, right? So if you're one of those 550,000 individuals who is exempt from this requirement, we'd like to tell you that. We don't want to force you to tell us that. And so we're trying to connect with as many data sources. Most of these we already have. Some of this we can use existing data that we have, and so that's good news. But then we also want to automate as much of the process of demonstrating compliance for those who are subject to the requirements as possible. Similar to what we just talked about with that ex parte renewal process, we want to be able to ping payroll. We want to be able to ping higher education data systems and determine definitively if this person's meeting the requirements without them having to upload documents, log on to a portal, do that sort of thing. But then some people will. That's just the fact. Some people are going to have to engage with a portal and a human in order to demonstrate compliance with these new requirements. So we're building the capacity to do that. And so that's going to be, we're trying to be as sort of tech enabled as possible, because that's how people engage with programs and with systems now, through their mobile phone, through their laptop. So we want to avoid people having to, drive to a brick and mortar place if they don't have to. Want to make it easy to upload pay stubs, recognize that document, demonstrate compliance. But also on the capacity side, just recognizing that the every 6 month redetermination and these work and community engagement requirements are going to add a lot of workload on state and local resources, is we need to build that capacity. One strategy is we have a centralized sort of call center and eligibility hub called Cover Virginia. They do not currently do renewals for any Medicaid members. Those are all processed by local DSS offices because they connect to other cases, they connect to other programs. But for those that are just Medicaid and just Medicaid expansion, we're going to enable Cover Virginia to do them. That'll reduce some burden from the locals. And then we will be staffing up at DMAS primarily to make sure that this is sort of oversee the program, make sure that dots are being connected, troubleshoot issues, and communicate policy changes out to the community. And then those last two, a lot of cross-agency collaboration, a lot of collaboration with community stakeholders. We learned this through unwinding. Communication is going to be key. Individuals who have to report and have to comply need to know that first. And so we're going to be, there's going to be a heavy focus on collaboration. And then training all those workers who have to do the work, because these are new requirements, new policies, new processes. Okay, rural health transformation. This gets talked about a lot, but yes, it is part of HR 1. So just a quick slide here. We have been awarded $189 million for year 1. Those are the 4 buckets of initiatives. You can think about them. That first one, sort of the tech innovation space. Number 2 is the workforce space. Number 3 is how do we bring providers closer to people? I mean, that's the primary challenge in a lot of rural areas. And so we're talking about hybrid care, telehealth, mobile units, a lot of different strategies that the community really brought forward under that 3rd bucket. That's the biggest funding bucket there. And then Live Well Together is a lot more of I would say sort of behavior change and sort of community development. So food as medicine is in there. There's certain, how do we enable technology to sort of empower individuals to take control over their own health? Some of those things are in that last bucket. DMAS is hiring staff, getting a contractor on board to handle some of the back-end grants management components of this. But these funds will all be awarded through competitive RFAs, requests for application. So I know you probably have providers or community groups in your communities who have asked you about this. They've certainly asked me about it. And the answer is you haven't missed the train. The train has not left the station yet. There will be, as they get developed, there will be a landing page where all of that information can be communicated. We'll have a listserv so people can sign up to get updates. But no one has missed the opportunity to apply for these funds. They awarded them. We get 2 years to spend the first year of money, and the federal government recognizing that every state's sort of building this as they go. So we will start to get that money flowing in 2026, and then we have through September 30, 2027 to get that first year money out the door. Last piece here on HR 1. There's a lot of talk about this back in the summer. Obviously, a key provision. Less talk this year because it's in the out years a little bit, but it'll be here before we know it. Essentially, there are 2 ways that HR 1 is going to reduce federal funding to certain providers, depending on the state. And in Virginia, that is going to be private acute care hospitals. So, one way is they're shrinking essentially the total pie that a state can tax their providers as to draw down additional federal resources. That starts to drop the percent. They call it net patient revenue, but the percent of net patient revenue that's the maximum a state can assess those providers is going to start to drop in 2027 by 0.5% until it gets down to 3.5%. So from 6% to 3.5%. On the other side, they're also trying to align the aggregate payment that a provider receives with the Medicare rates for a similar suite of services. And so again, starting in 2028, any state that's over 100% Medicare in the aggregate, which Virginia is, has got to reduce that with a 10% step down until they get to 100% of Medicare. And so these reductions in federal payments will phase in over a long period of time. They'll start in about a year and a half. And then it will, over time, result in substantial funding reductions from the federal government to Virginia's private hospitals. All right, that's the end of HR 1. Any questions?
May as well jump in now, and I apologize, my little notification board is down, so just give me a little wave. I think we've got Delegate Cole with a question. Go right ahead.
Thank you, Chair. I have a bunch of questions, but they're all mostly related around process. Some of them you answered in regards to people potentially. I feel like a lot of the questions that we're going to get from constituents is people getting caught in the gap between getting dropped because they have to recertify or requalify for services, and then going through a new process, a changed process for getting re-verified or qualified as eligible for services, and when they're not, because I think some of the intent of this is for less people to be eligible. What types of help do we have to direct those constituents to at that point?
Yeah, it's a really good question. I think I'll answer it 2 ways. Number one is we will be able to get you all sort of some consumer-facing materials so that you'll have something to give them, a phone number to call, a website to go to. Because I think, the first part of that question, what I'm hearing is the angst of, I don't know where to go. I don't know how to demonstrate that I'm eligible. I may still be eligible, but I could lose coverage because I don't know what to do. That's what we've got to avoid. And so we want to over-communicate, and we will leverage you all as partners because you hear from a lot of these constituents. And so to give you very easy resources, here's a QR code, or here's a number, or here's the link to where you need to go. And that way they at least can provide the information the state needs to make that determination. Now, for those who either are no longer eligible due to income, or they're subject to the work requirements and they're not meeting those requirements. That's where that's a tougher question. I think if you're over income, the state-based exchange is where you'll go. Obviously, there's changes to the subsidies going on there, so that's another challenge. But that is still sort of the next step, sort of in the health coverage continuum. For those who may be Medicaid eligible, except they're not working or engaged in education, that's where we've got to build out the supports, the case management, and making sure they can get connected to the right resources. And so more to come on that. Again, we're building out this plan as we speak, but that's an important part of the plan.
Thank you. Delegate Hope.
Thank you, Mr. Chairman. It's good to see you again, Jeff.
Likewise.
I want to follow up on Delegate Cole's question because we are going to have several people that are going to be ineligible, and maybe it's SNAP or TANF benefits. And I want to make sure that the administration is doing everything it can to ensure that people, that if they are eligible, I guess my concern is who's making the decisions? Is the decision being made in Washington with some new rules, or is it being made by Virginia at DMAS? And I had a bill which you were particularly helpful with, and I appreciate the agency. It had a fiscal impact on it, and it died in Senate Finance. But people should have the right to appeal decisions that they believe are incorrect. And so I want to understand what the administration will be doing when those people are, first, who's going to be making the decision for who's eligible? And if their rights are to appeal, will they help them do that so that they can continue with their benefits? Because people who are eligible are struggling, and they are going to need that support during that interim.
Yeah. A couple parts to that question. I think on the policy side, and it goes back to those state options we had a few slides ago. There you go. On the bottom right. So the short answer is, within what the federal government will allow Virginia to do, this administration and the Spanberger administration will be able to make the decisions on what policies we implement. So, again, you could look at, are we able to do hardship waivers for if you live in a county with high unemployment? If we have flexibility in how we define medical frailty, are there certain types of work, community engagement where we are able to accept attestation, versus documentation and an electronic data source? Those are some of the policy choices where, within what the federal government will require, the Spanberger administration will have the ability to make that consumer friendly. So I think that's on the policy side. I'm sorry? There is some. And we will have more clarity this summer once the final guidance comes out on just how much flexibility there is. Within what we know from what's written in the law and sort of the informal guidance that's come out, we have a pretty good sense. And so we are making decisions to be as flexible as we can, recognizing they're preliminary till final guidance comes out. And we can have an offline on the appeals bill. I totally understand. There is an appeal process currently. I understand what your bill was trying to accomplish. And we were a bit surprised by the ultimate result as well. But yeah, we should talk. Thanks.
Delegate Waxman.
Thank you, Mr. Chair. And also, I really appreciate this conversation. I think it's quite prudent that we have the ability to interact like this. I represent a very rural, very low-income population with very few providers. With the transitional money for rural hospitals, how much of that money is actually going to benefit those rural hospitals to help keep them in business versus grants that are going to other healthcare providers to support that area? My concern is I don't know that we're doing enough to really help save those rural hospitals from despairing.
Yeah, it's a really good question, Delegate Waxman. And I think, so how much is going to go to hospitals versus other providers? That'll be driven by that competitive process. One clarification I do need to make, though. It was very explicit that this money cannot be used to backfill reductions or to pay for existing services. While it was sort of part of the political compromise, to get the bill passed, it explicitly, we can't just supplement Medicaid reimbursement to rural hospitals with the Rural Health Transformation Program. It is one-time money. Sustainability of these initiatives is important in terms of how we apply that. So I guess it's an unsatisfying answer, and I apologize for that. But, hospitals are absolutely going to be, I think, a key eligible applicant type for a lot of these initiatives. Within these 4, there's actually 15 total sub-initiatives. Each of them will have a request for applications, and some of them are very specifically targeted to hospitals. As a matter of fact, the VHHA Foundation is going to be sort of the arms and legs for a couple of them because they are targeted specific to hospitals, and they've got that grants management capability. But again, I will emphasize that we are required, and what our application proposes is to make these sort of new initiatives that can hopefully change models of care. We're not allowed to essentially increase reimbursement or keep hospitals afloat using this money.
Right. Mr. Chair, if I could do another question.
Yes, please.
Earlier in your presentation, you mentioned that it seemed like the push was going to be more for technology because that's how people are interacting now. The area that I represent, once again, being a very elderly population that's low income, I don't necessarily believe that that is the correct measure to take. A lot of the people, when I had my pharmacy, would come in to try to get me to help do the work for them, which I oftentimes didn't have the expertise. And a lot of people in my community do not operate very well under the technology. So I hope that is kept in mind as well, too.
Yeah, absolutely. And just to clarify, because I was probably speaking pretty quickly, I think some of these under rural health are tech specific. But again, that's why you go through a competitive RFA process. The community will come to the grant maker, essentially the state, and say, here's what's needed in our community, here's how we want to do it. So the actual proposals and grants will be community driven, and that's why there's a pretty broad suite of initiatives. I think, and I remember that specific comment. I was actually speaking specifically about the eligibility changes under HR1 because that's targeted at our younger Medicaid population. That's our low-income adults. And so, we've learned a lot through the expansion rollout, through the public health emergency, and the unwinding in terms of how they interact with our eligibility system. So I was speaking pretty specifically about one target.
Just a word that I'm afraid we're starting to lose some of those people that have definite needs that are in that elderly population. Thank you.
Point well taken.
Thank you. Delegate Cornett.
Thank you, Mr. Chairman. Much like Delegate Waxman, I have a very rural and high Medicaid population in my district. And with the Medicaid eligibility redetermination, do you have a sense of the automated process on what the percentage is that will automatically be determined eligible?
Good question. Sarah, should I try to answer that or should we follow up? You can come up. I don't have the answer to that question.
Come on up.
This is Sarah Cariano.
Thank you, Sarah.
Good afternoon, committee. Sarah Cariano, Director of Eligibility Policy at DMAS. So currently, the Medicaid expansion population doesn't have the resource test, and so for that population, we do have a much higher ex parte rate, which is that automatic, and we can get you the exact numbers. Throughout the whole population, it's about 50%, but I can get you the exact numbers for the MAGI population. The challenge is these are new requirements, and so we don't know exactly how successful we will be in confirming the exemptions and the work compliance. So we can give you kind of the numbers for what we have right now, but in terms of the implementation of the new requirements for that population, we'll definitely continue to we can do reporting, we can give you kind of that data as we're going through, and it's something that we definitely are going to have to report to CMS, and so we're going to be tracking it very closely.
Thank you.
Thank you. Delegate Downey.
Yeah, thank you for the presentation. I've been a pediatrician for 25 years, and I was worried about the the covering being reduced from 3 months to 2 months, because a lot of times the patients aren't, and the infants aren't added to the policy, and a lot of times we're seeing them for a well visit right after the hospital at 2 weeks, at 1 month, and 2 months, and we typically hold those bills until they get their Medicaid. Is this part of the exemptions? Are they going to be, like, I know there's exemptions for pregnant moms and postpartum, but what about the newborns that?
So, yeah, just to clarify and try to separate two different policies in HR 1. The exemptions we're talking about are specific to those work and community engagement requirements. That's just for the adults, the Medicaid expansion population. The reduction in retroactive eligibility is sort of a hard reduction from 3 months to 2 months. I would say Sarah will be the absolute best person. Maybe we'll connect you off. Oh, or you can just answer. I didn't realize you were still standing there.
Yeah, I thought there might be another question. Specific to newborns, if the mother is covered by Medicaid or FAMUS, they are still what's called a deemed newborn. And so while that active enrollment may take a little bit of time, depending on when it's reported to the state, they are automatically eligible for that first year of life. We enroll them without having to wait for the Social Security number to get given to the family. And then just to clarify the retroactive coverage, if when you're found effective is effective the first of the month that you apply. And so again, even if it takes a little bit for a new application, say that mother is not covered, they come to the hospital helps them both apply, right? Even if it takes a little bit of time to get that application processed, it goes back to the first of the month of the application, and then we review for that retroactive eligibility. And so for that pregnant individual and the child, they would still be eligible for those 2 months before the application, not necessarily the enrollment.
Thank you.
Thank you. Delegate Hodges.
Thank you, Mr. Chairman. A couple of things. Of course, this is going to be a daunting task, and it already is, and it's an uphill. I mean, you go on, uphill fight. So with the technology, the apps, and so forth as well, how long would it take someone to possibly go through that and to complete that?
You talking about for the work requirements?
For the work requirements and so forth.
It's going to depend on what they have to demonstrate.
Sure.
Again, I'm not trying to be coy. If it's uploading a pay stub, the goal and frankly the IT demos that we've seen are pretty quick. What we're trying to build is something that I'll speak from my personal experience. The way I bank, right? Anymore, I don't go to a bank. I deposit a check on my phone. Trying to get at something like that. If you have to upload a pay stub, you take a picture of it. There's intelligent document recognition in the background that reads that, pulls the key information out of that, and hopefully in a couple 3 minutes, the system can churn and verify that this meets the requirements. That's the best case scenario. I can't promise you it's going to be that easy for everybody.
Gotcha. Follow up, Mr. Chairman.
Yeah, please.
Appreciate that. The delegates' questions about the rural areas and access to internet, not knowing how to use computers and so forth. I'm afraid some people may ignore that, and then they end up at their local DSS, and of course, the workload there, it's going to be quite a workload. Would it be possible to say a community have at the library to have an event where, I shouldn't say event necessarily, but where folks can come in and do this at the library, and if they need assistance uploading that document and so forth as well, that could really help speed this process up. Are there any issues you would see with that?
Yeah, I mean, specific to the example, no. And I think one thing to really understand is we are still going to have our current network of application assisters, that we fund and are out there in the communities. They're going to be a key part of this. They will help individuals navigate. So, while I'm emphasizing sort of tech-enabled and, automated eligibility, we completely understand that there's going to be a group of this population that is going to need a person to help them walk through. And so we're not, I didn't mean to minimize that component of this, because that is still going to be a part of our eligibility, ecosystem, and something where we will be communicating closely with them, and then they will be out being able to help individuals.
Okay. Thank you.
Yeah. Jeff, coming back to answer, I think, this question in part, but the automation part of this. So just high level, how much of a mixture is it going to be of current systems versus new systems, current partners, new partners? I mean, because my biggest concern is just the timeline. And again, that's not your fault.
Yep.
There's the cards we've been dealt here, but the timeline is daunting. And so I'm questioning, and I've worked in state system implementations in my private life, so I know that's hard on a good day. So I'm just curious what the mixture might be.
No, it's a fair question. I think the best way to think about this from a Medicaid perspective, and keep in mind the administration's got to look at this globally. So we're implementing new things on the SNAP side, new things on the Medicaid side, but I'll speak specific to Medicaid. There are going to be changes to our core eligibility system that's called VACMS. Because they've got to be able to intake whether someone is now meeting this requirement. They've got to send the notice for renewal every 6 months, or before that, they've got to try to ex parte renew the person, and then if they can't do that, then they got to send the notice. So our existing system's going to have a lot of changes. Those are scheduled. They've been scheduled for a while, and they'll be in place, on time this fall. So the things we can do to our current system, feel pretty good about. What we are needing to build that's new is, and don't think of it as a system. Like VACMS is a big integrated system. It's not what we're building for Medicaid work community engagement requirements. What we're really building are some capabilities and a front end for the consumer, right? So the ability to take in a document, recognize whether you meet eligibility, and then feed that into VACMS, right? That functionality has to be built. On the communication side, trying to build like two-way communication with an individual where, we reach out to them either by email or by text message, like, hey, you're due, you've got to demonstrate compliance, click this link, go to the portal, like that kind of thing. And we are working with a vendor to build that out, finalizing, requirements and timelines right now with that vendor. I would say the good news is vendors want this business and every state's got to do it. So there are products and there are vendors that CMS has actually said, here's a short list. These vendors have what CMS calls MVP, minimum viable product. These vendors have demonstrated they can do this, and they've all got to do it on time. And so it will be tight. It will be hard. But I think we're doing everything we can to get there.
Thank you. You're popular. We get a lot of questions. It's good.
Yeah, we may skip the other Medicaid initiatives to be nice to be sensitive to Dr. Webb.
Delegate Hope, go to you.
Thank you, Mr. Chairman. I do have a follow-up, but it's probably, maybe it's more for Mr. Ford. It's relating to the Nancy Munn tribe and the investigation there. And if you don't have an answer today, I'd appreciate you getting back to my office on that. I know that they are alleging that there's some withholding of some Medicaid funding, and it goes directly to their financial viability. And so I'd appreciate if there's something you can say today, or if you can get back to my office, I'd like to understand DMAS's position on that issue, because I know that they're financially struggling.
Yeah, unfortunately for me, it's a get back to you, but we absolutely will. I'm aware, and I'm wrapping my arms around that, but
okay.
Not at the point yet, 4 days in, to have an answer for you today.
Okay.
But yeah, we'll get back to you.
I appreciate it. Thank you.
Okay. Delegate Gardner.
Thank you, Mr. Chair. Jeff, excuse me. I had a town hall last night, and some of the questions related to the Medicaid work requirement was about homeless people, and do you guys have a plan in place for that, and how is that going to work?
That's a good question. I would say, Sarah, are there exemptions specific to homelessness? No. Okay. So again, I think what we've got to figure out is the people who are going to need outreach. How do we reach them now? And then how do we leverage those avenues to reach them, in the future? What I will say is, I think there's, the medical needs that we know through claims data is part of what we can use to potentially demonstrate medical frailty. And so there may be some exemptions there, but I do think, to your point, there will be individuals who are homeless and who need to demonstrate, compliance, be connected with resources. And so it's an important population that we've got to figure out how to communicate with and how to support them.
Follow up, Mr. Chair. Somewhere I read or heard or somebody told me, sounds crazy, but that the requirements were sometimes they were not just work, there was like volunteer. And so can you just elaborate a little bit on that it's not just work? Sure.
Yeah, and again, there's a whole list in the law, and then the guidance is going to be more, I think, crystal clear about what qualifies for those other things. So there's work, but then you can volunteer, you can be enrolled in education. or a degree, or a certificate program, and sort of what qualifies as volunteerism, and also work in this day and age of the gig economy, is definitely an open question. And those are some of those policy flexibilities Delegate Hope was talking about that the state is working to define right now, and then we'll adjust when we get final guidance. But yes, there's, I won't say it's like a super broad set of kind of activities that will qualify, but it's definitely not just work.
Thank you, Mr. Chair.
Delegate Cole.
Thank you, Mr. Chair. My question this time is about in regards to the vendors. I know there, I would imagine there's a wide scope of vendors that we're looking for to provide different types of services. I know some of my clients provide services to the Medicaid population have been affected by, not the lack of reimbursements and things like that. And so thinking, will there need to be certain certifications or licensure for vendors providing new services that will be needed through because of these new requirements, so that the ones who are impacted by their, how they typically provide services, they can maybe modify to provide other services so that they can, still grow and build their revenues.
Are you talking like providers, or are you talking about like system IT vendors? I just want to make sure I understand the question.
Okay, so I guess I'm thinking more on the providers of assisting the clients or patients, people who are eligible for Medicaid to go through the process, right? The application process, where it's going to be services that we haven't had to provide to people to sort of shepherd them through before, not so much IT.
I gotcha. No, there's nothing in HR 1 that I'm aware of, and Sarah will correct me if I'm wrong, that would directly impact sort of that sphere of folks who support individuals. I think they'll be critical, again, because we're increasing the amount of eligibility work that the consumer has to do, that the state has to do. And so everyone who's involved in that certainly, I think, will want to actively engage.
Jeff, we've got one more question for you, and I really appreciate you indulging us all these questions. Delegate Hodges.
Just a statement, Mr. Chairman. And following up on what Delegate Hope asked about the tribes, the federally recognized tribes create a tremendous opportunity for the Commonwealth to provide access, improve outcomes, not only for tribal members, but also for the entire state. And to improve that relationship and to be able to, come together can create a tremendous opportunity to help a number of people. So that's it.
I agree. Jeff, thank you so much. Maybe we'll pivot.
That's totally fine.
For the committee's benefit and the audience's benefit, we are going to, I think I mentioned this last time, do our, we used to call it the Mark Sickles Medicaid Boot Camp. We're going to expand on that a bit, but we are going to try to meet this summer to continue this conversation. So thank you so much. Steve, thank you. Welcome. You got it all covered. You're good. A lot of confidence. Sarah, thank you as well. Really appreciate your time. We're going to pivot right to Commissioner Webb and have him come on up to join us. Thank you. Thank you so much for coming back, and it's good to have you here.
Thanks so much for having me. Good to see you all. First, a quick comment on my decidedly UVA tie. The UVA women are playing in the ACC tournament in about an hour and a half, so wishing them luck against another orange and blue team, the Clemson Tigers. But UVA's got to go get to that NCAA tournament. It's great to be with you, and going to share a little bit of information per your request. Wanted to start with just a quick presentation overview. I'll give a brief on kind of how things have been going for the first month and a half in my role, and then the two specific areas that we wanted to talk about today are the Office of Licensure and Certification and our Ryan White program. So just in terms of introductions, keeping in mind the mission of the Virginia Department of Health, it's to protect the health and promote the well-being of all people in Virginia. Now, we have some focused efforts that we've really been teeing up in terms of accountability, community-centered engagement, building trust, prioritizing equity at the core of these first couple of months that have been in this role in 2026. And we're doing that through a couple of things. First, prioritizing community and staff voice through a commissioner's listening tour that I'll describe in a moment. Some clear commitments to actions with goals and progress updates. We'll talk more about that as well. Maintaining an emergency response excellence. Of course, we had the winter storm, I think right after the last time I was before you all earlier in January, but continuing to be excellent in terms of that emergency response. Adding some clarity around childhood vaccinations, again, for us, aligning with the American Academy of Pediatrics and kind of following the science in terms of what those recommendations are for children here in Virginia. Continuing to elevate critical public health messaging, and then at its core, kind of centering science and public health best practices. We actually had a press release yesterday where Virginia joined the Northeast Public Health Collaborative, which from a technical standpoint, some great work groups allowing us to collaborate with peers and colleagues really across the East Coast and kind of the northern part of the East Coast, so that we're understanding what's happening, understanding how we can work together. Of course, public health challenges don't know state borders, and so it's important for us to stay collaborative. In terms of the commissioner brief, I'm jealous of Director Ford because he can still say 4 days, and now I have to say 45. But 45 days in, a couple of things that we've learned. So I started this 75-day listening tour on day one. And there were a couple of things that we wanted to do, meeting with key state and local stakeholders, hosting receptions, having meet and greets, one-on-ones, and various briefings. We've met with over 60 organizations, different state agencies. We've had listening sections with 16 VDH state and local health directors so far. Is my time up already? No, I'm just joking. Got the hook early. And then meeting regionally with our local health directors as well, getting direct input from over 170 staff here at VDH. We met with the Employee Advisory Council to get some feedback. So by the end of these 75 days, really a couple of goals. We want to have kind of a collective picture of the agency, but also a 360 view of the public health challenges here in the Commonwealth. And that's really the goal of getting out and engaging. Of course, describe it as a 75-day listening tour. That's just the beginning. Obviously, we'll be listening kind of throughout our time, but I'm really trying to jumpstart that with this effort. And just this timeline that you have on the screen kind of talks through today's day 45. Actually, this concludes right before National Public Health Week. So we'll use that week to talk a lot about what we've learned and how we want to use that to launch the path forward. A couple of early themes I want to share with you that I've heard just in these first 45 days. And the first is a really clarion call from all corners that the agency should operate with excellence. And that'll be a theme in today's conversation. But as we are executing the work, the mission of this agency, making sure that we're doing it at the highest level of excellence. The second is restore trust in public health. We do that really not acting on whims, but really on following science to every extent that we can by being transparent and by engaging community early and often. And again, it's a key part in how we restore trust. And then the final piece is centering health equity. Again, that's the idea that all Virginians should have the opportunity to be healthy and really just thinking about, the rural communities that you described, how we can serve them really well and really thoughtfully and meet their needs uniquely. And at the same time, reach all the communities that have unique and dynamic needs. And so that's one of our goals and something that we've heard certainly early in this listening tour. So I want to turn to the two topics that we wanted to focus on today. The first being the Office of Licensure and Certification. Just to describe that office, it implements and oversees our state licensure programs of medical facilities, and that's through inspections and state and complaint investigations. It has three main divisions. So first is our acute care services, next is long-term care services, and then health services planning and oversight. And it also has a separate complaint unit that services across those three divisions. And it serves as the state survey agency. So for CMS, it is kind of our surveying agency and entity. It does the certification and registration programs for managed care health insurance plans, also runs our Certificate of Public Need program, our COPN program. And then finally is the active supervisor of our cooperative agreement involving Ballad Health in the southwestern part of the state. So in terms of nursing home certification, which again, double clicking, this is the issue we want to touch on today. Facilities initially apply for federal certification. The recertification process, however, is not, there's no reapplication that's required. But instead, we are expected to go in and survey all these nursing homes. CMS has a target of just under 16 months interval between surveys. But all of our surveys are unannounced. So the facilities don't know that when we're coming, and that's to ensure kind of the integrity of the process, make sure that we're able to see them as they operate typically. The purpose here to ensure compliance with federal requirements, to verify the provision of quality care, and to protect the rights of the residents. And then survey deficiencies are scored in terms of scope and severity. So just to quickly describe that, the scope is if it's an isolated issue, there's a pattern of an issue, or it's widespread. So that's across the top. And then you see the severity that we describe as well, whether there's immediate jeopardy to the resident health and safety, whether there's an actual harm, but it's not immediate jeopardy. And then the last two categories, no actual harm, but potential for more than minimum harm, and then no actual harm with potential for minimum harm. So I think across the board, the idea here is that this is what our inspectors are going in as they're doing surveys to identify. So in terms of how things are going, so OLC has been operating with a very significant recertification backlog, which has been driven by capacity constraints and workforce certification gaps. And I'll talk about that in a second. So total statewide, we've got 289 nursing homes. And the number of facilities that are currently out of compliance with that target from CMS, just under 16 months, currently about 69% of our facilities. It's been longer than that, 15.9 months since they were recertified. And so, coming in, we, clearly identified this is an area we need to improve on and improve on urgently. Just to give you a sense of the staffing snapshot, because that's going to connect to how we approach this challenge, we have 39 dedicated MFIs, or medical facilities inspectors. 25 are fully certified, and then 14 are currently still requiring certification. To give you some context, one of the issues identified last summer was that we had about a 40% vacancy rate in these positions. And so by hiring folks, bringing folks in to do these surveys, we know we're going to be able to clear this backlog more efficiently. But for most states, they give somewhere between 12 and 24 months for newly hired MFIs to become certified. Here in Virginia, and we'll talk about it, we've come up with a plan to do that thoughtfully and efficiently, try to compress that timeline so that we can get folks in the field a little bit faster. So there are 6 MFI supervisors. We also have inspectors for life safety code, so they're looking at building standards. Just added a Northern Virginia team in January to focus there. And so we have 5 fully operational regional survey teams that are conducting our long-term care recertification statewide. Each team has both certified and non-certified medical facilities inspectors. And they are operational through the joint surveys, supervisory oversight, and workload balancing. That's how we make sure they're able to continue to do their work. This is kind of a chart of really our plan, our roadmap to getting to completely clear this backlog by January of next year. With our teams in place, our teams currently in place, we have our 5 long-term care surveyor teams. We've set a very realistic but ambitious target of 18 recertifications per month. And in doing so, again, 4 recertifications per month each for each of the teams, that gives us an output of about 20 recertifications a month. That allows us to completely clear this backlog by next January. And that's with our current teams that are in place. We've been getting weekly reports from these teams to make sure that we're hitting those targets in the early days of this initiative, of this effort. But more than that, we're giving priority to certain areas. We wanted to identify what are our longest overdue facilities, and let's get in there first and make sure that we're identifying any needs or challenges. We're looking to our facilities with prior enforcement history. And then finally, our facilities that have multiple complaints. By really looking at those 3 areas, our thought in terms of prioritization is we're going to not only clear this backlog, but also get to the highest need areas first. And so that's one of the ways we've really operationalized this goal of clearing this backlog. Now, that's not the only thing that our teams are responding to. Nursing home complaints are a key part of this dynamic. I mentioned we have a complaints team. I'll talk about that in a second. But this is just a snapshot of our February data. In terms of nursing home complaints received in February, it was 148. And yet we still completed 96 nursing home investigations in terms of complaints. And so that's a lot of complaints that we were able to respond to. But the challenge is that every day, every week, we're getting so many more of these complaints coming in. And to be clear, this is important. It's important for people to be able to reach out and engage when there are potential problems at our nursing homes. And it's important that we respond to that thoughtfully and diligently. But I think what we realize is that because there's more coming in than there are going out, we need some more help. The team that does that addresses these nursing home complaints is a relatively small team. It's 3 individuals, and they're responding to a lot of these complaints in real time. Of course, we have to prioritize them in terms of immediate jeopardy being the highest prioritization. We have to respond to those within 3 days. That's a relatively small sliver, a little less than 1% of the overall cases. Most of them kind of fall in that third category where there's a potential risk of harm, but it hasn't actually manifested yet. But even still, it's important for us to find a way to get to these complaints thoughtfully. I'll talk you through how we're doing that. We have kind of these 3 phases in terms of priorities. And the first is that we identify all of our immediate jeopardy and high-risk complaints. We escalate those to the survey leadership, and we get that inspection done, that evaluation done as soon as possible. The second phase is looking at those non-immediate jeopardy medium and the low-risk complaints. And we're actually grouping those with the recertification surveys. So we're both tying that to our process of clearing that backlog, but also making sure that we're getting to those complaints in a timely fashion. So our goal is to have 100% of those complaints contained within an electronic system, keep that clear separation between complaint intake data and data entry and survey execution so that we can do this seamlessly, thoughtfully, and efficiently. And so, this, again, with the size of our work team presently, would be very challenging. As you know, the introduced budget, we wanted 2 additional medical facility inspectors to address that backlog. That was what was in the governor's budget. Of course, we want to thank you all for the version of the budget that you put forward, which of course includes funding for 6 additional medical facility inspectors for a total of 8. And that's precisely what we've estimated would be necessary for us to clear this sizable backlog. If you think about the folks that you represent, this is what they need, right? They want folks in a timely fashion responding. So we thank you for your diligence and your thoughtfulness in getting us what's needed for this paradigm to work. A couple of regulatory actions that are still pending that I know you all requested an update on. So nursing staffing standards, of course, 2023, there was a standard about 3.08 hours of case mix adjusted total nurse staffing hours per resident per day on average. There was the State Board of Health promulgated a NOIRA, or Notice of Intended Regulatory Action, and then CMS imposed the federal standard, and so the Virginia standard was repealed. The federal standard was subsequently repealed, and that leaves us with this year, of course, we're introducing and amending into a Section 1 bill directing JCHC to study the nursing home working force so we can move this forward, figure out exactly what that standard should be as we move forward. The next is the intermediate sanctions. So this was a new authority from last year that was given to our agency to place a nursing home on probation or impose civil penalties up to $500 per violation per day, capped at $10,000. And so those regulations are currently under development by the agency, and they're subject to requirements of the APA. And then finally, the nursing home and hospital licensure fee increase, really an important piece here. So the Board of Health authorized a set fee schedule to cover the cost of operating the nursing home licensure and inspection program. Of course, that hadn't been updated since, I believe, 1979, so it was very out of date in terms of the amount of those fees. So by increasing that, it also allows us to support the staff who are doing the inspections and do it in a way that's commensurate to the need. And so that's under emergency regulation action. It's going to be under review by our secretariat right now. So in terms of where we were, we had a significant recertification and complaint inspection backlog, high OLC staff vacancy rates, workforce instability. We had delayed survey cycles. We had limited data visibility into real-time performance. And we had really reactive operational posture. And so the things that we've done, I've described some of these, but improving our operational processes. And so that's the first, optimizing our workforce, and we've talked about adding folks to get the work done, enhancing our training. So we've actually made it so that our newly hired MFIs are ready to take that test for SMQT qualification within 8 months instead of the usual 12 to 18 months that we're seeing in some other states. So we're trying to get them ready sooner and then creating really structured plans to help get them there if they're not quite ready, even at 8 months. But that allows us to compress that timeline, get folks in the field a little bit faster. More work around data and performance management, expanding our resources and capacity, and then expanding the transparency and accountability of this program through conversations like this, but also through our ongoing engagement in the field. And so that takes us to kind of where we are. So we have a stabilized leadership structure. Of course, we have a new team at OLC that came in late summer last year. The director, deputy director, we brought in that new leadership team. They've been able to kind of see this problem and start from there to move this in the direction that it needs to go. We've reduced those vacancy rates in key program areas. So we have this backlog reduction strategy that is well underway, and so we're excited about that. The reality is that, from the high water mark when we first came in to getting to about 50% of those facilities, we expect we'll be there by the end of May. 50% of facilities will be at that target, and I think we're going to just continue making progress from there. And then enhancing the complaint triage and prioritization, that approach that I described to you, that helps us make sure we're getting to the more challenging areas sooner. Increase stakeholder engagement and transparency. And then where we're going, really want this predictable on-time survey cycles, data-driven risk prioritization, as we described, and then having fully staffed and cross-trained survey teams so that we can stay in the field, accelerating that training process as I described, and then finally, a sustainable infrastructure that prevents future backlog. And I think you all are helping us achieve just that. So beyond nursing homes, I want to describe that we're not just focused. I mentioned there's a couple of areas where we do certifications. So our current goal, we have our current staffing and resources, but as we move toward an increase in OLC revenue and resources with the fee structure and some of the support from you all, what we're finding is that we're going to be able to do this really beyond just the nursing home space. So yes, we also do inspections in hospitals, in hospice, and different spaces. So it's important for us to stay on top of all of those. Additional goals, again, we want to maintain a low vacancy rate. We want to stabilize that pipeline of certified individuals, and then kind of stay really transparent in terms of reducing that backlog. And then ultimately, as I said, sustain this inspection cadence so it's reliable, predictable, and we know where we're headed. So I'll stop there on nursing homes. Happy to take a couple questions on nursing homes before turning toward Ryan White.
Dr. Webb, thank you so much. And I apologize, this is the way things work around here. I had to step out for a minute because my bill that you just talked about related to nursing home standards was up in the Senate Education. You cannot make this up. And there's a little bit of an issue there, but that is going to move forward. Incredible coincidence. I want to thank you for what you've done. This is tremendous progress. We had a tremendous issue to deal with. You have come in and literally in a matter of weeks just made incredible progress. So I really want to thank you for that. We're still getting down the road, and I think we hopefully keep covering your back there with the staffing you mentioned. We really want to get that through. I like the House version that you like of that. But I really want to thank you for that. It was a dire need. This affects all of us, family members, a lot of constituents who were affected by these subpar nursing homes. So you're on it, and I really appreciate that.
Well, thank you for that, but I have to give credit to April Doval, who's our director here, and Jim Jenkins from our OLC team. When I tell you they're passionate about this issue from day one, they've been bringing really thoughtful, ambitious ideas, and just really grateful for a strong team leading this work.
Yeah. Let's go to Delegate Henson.
Thank you, Mr. Chair. I actually have a kudos and then a question at the same time. So the kudos is, I believe on your first or second slide, you discussed elevating critical messaging. And I know dealing with what's been happening with the Potomac River and the spill and the E. coli, when I contacted the Department of Environmental Quality, they already said y'all were on top of it when it came to critical messaging, making sure people stayed out of the water. So I just want to let my colleagues know that that's already been happening way before we even started having those conversations. So kudos to your team for that. But my question was relating to the NOVA team established for nursing home regs. Was that a gap that you all found, or was it just your team being ambitious, or was there a growing need? How did that team come about?
And certainly I think April could speak to that a little bit more, but my understanding is that there certainly was increased need in the Northern Virginia area. And I think by having a team physically there as opposed to having to travel there to do the work, it was going to go a little smoother. Is that about right? They said I got it right, so
Okay.
I'll take it.
Thank you.
Mm-hmm.
Delegate Tran.
Thank you, Mr. Chair. Commissioner, I just wanted to echo the chair's appreciation of the work that you and April and Jim and the whole team are doing around addressing the level of care at our nursing home facilities. And I've heard some stories from my own constituents that are really troubling, and I just appreciate the oversight and the attention to that. Some of our most vulnerable, beloved family members are there, and we want to make sure that everybody is able to age and heal with dignity. And thank you for taking that so seriously.
Definitely. And just to add, I think a lot of those stories that we're hearing from your constituents are helpful for us. You know, again, as we're digging out of this backlog, you know, there's time that's going to pass where we still have some facilities that we haven't gotten to. But our hope is that by the time we have these conversations in the next year, it's a very different state. And we're able to say with a lot of confidence we've engaged all of our facilities.
Thank you. Delegate Waxman.
Thank you, Mr. Chair. A couple questions. About a year ago, I had a chance to do a deeper dive into the nursing home situation. Are the inspectors for the nursing homes currently registered nurses?
So it sounds like most of them are.
Okay. And I know that we, about a year ago, realized that things were kind of falling off the wheels with complaints that I was receiving in the area, as well as I'm sure my colleagues were too. And I kind of have to question, when COVID hit, particularly nurses' salaries really increased. The same time that was happening, loved ones weren't able to communicate with their loved ones in these residences, and I think that increased the complaints as also staff dealt with that. The increased complaints got people further behind because, as you point in your presentation, you have to go inspect those first. My question is, what we're offering the nurses for these inspection positions, have that kept up with the market that increased so quickly?
I think that, you know, I'll say generally it's been hard to keep up. I know that one of the big pieces of the strategy from late summer to help fill those vacancies was offering higher salaries to bring folks in. And I think part of our ongoing assessment, when we say we set a strategic goal of maintaining a vacancy rate of less than 10%, it's allowing us to respond to some of those pressures in the field to make sure that we're whether it's increasing salaries, and that's an ongoing conversation, whether it's making the job attractive in other ways to maintain that staff, because we do realize that's critical to the success of this endeavor.
Yeah, I kind of agree with that. And when you said 40%, I thought that was interesting because when I would go, my area also has the highest concentration of correctional facilities in any district in the state. And when I would go in and ask some of the directors about the situation with COs, we were finding out that they also were having a 40% absence of appropriate staff. So I'm afraid that this may be a symptom of multiple areas of our state. Thank you.
Thank you.
And Delegate Walker.
Thank you. So in my area, Lynchburg, Central Virginia area, we have a number of assisted living nursing homes, and it's an issue that has come to me over the last year. Certainly in workforce, there's a shortage out here when it comes to CNAs and things like that. One facility in particular had to lay off 15 people at one time because they weren't fluent in English, and this is individuals that are great workers, but part of the requirement was the ability to read, write, and communicate in English. Because when you're dealing with older people, sometimes hearing and other issues or challenges they may have, and that created quite an issue. And so I know that the requirements are in these nursing homes, assisted living, is to be able to communicate. I think that's something I'd like to discuss with you later, further, because it's only going to get a little bit worse in some of these rural areas that we have. And that's kind of where the challenge came from. And so I hope that may be something we can address at some point as we move forward here.
Yeah, we'd be
I
happy
just
to
wanted to
engage.
just bring that to your attention.
Yeah, no, thank you.
Very much.
Thank you for raising it.
Delegate Tran.
Thank you, Mr. Chair. I want to acknowledge that a large proportion of our workforce in nursing homes are immigrants and people of color. And I think when we start talking about like language tests and such as parts of work requirements, we're not acknowledging the care, the intentional, the patience, the dignity that many of individuals in the workforce right now are giving to people who are living in nursing facilities. And in my conversations with several of the nursing home and assisted living facility representatives this year, we talked about how diverse that workforce is. And it is because of the labor of immigrants, some new, some who've been here for a long time, who are willing to do this incredibly difficult and challenging work of giving care to our loved ones, that our loved ones are able to be in these places. And so I just want to be careful when we talk about kind of language thresholds and make sure that we have a qualified workforce that's able to provide the care in all the ways as you move forward with those conversations.
Absolutely appreciate those sentiments. Thank you.
Dr. Webb, we really want to hear in Ryan White, so I think if we can get a few more minutes, that would be great. You're covering some really important topics here.
Sure. So turning to Ryan White, I want to first describe the Ryan White Part B program. So really a couple of things. First goal, to improve the quality of and access to HIV healthcare and support in the United States, and then also to provide medications to low-income people with HIV through the AIDS Drug Assistance Program, or ADAP. So Part B grants, they fund medications, core medical services, and also support services. All of our Part B recipients and subrecipients, they must help eligible clients find health care coverage, and that's part of it. As I kind of start this conversation on Ryan White, I just want to be clear, this is a program that's critical, that's so important, and it's serving a really important demographic of folks who face a unique healthcare challenge. And so our goal is to do this with dignity and to do this really well. If you think about the Ryan White Part B program, really a couple of different components to go into it. So there's the Part B base grant, and that supports the core medical services and support services. Then there's the Part B supplemental, that's additional funds that's for states that can show that they need more assistance. There's ADAP, which is a base, a supplemental, and emergency relief pieces, but that helps low-income folks with HIV get the medications they need and coverage. And then emerging communities as well, providing additional funding to states that have a growing number of people with HIV and AIDS. Now, federal stipulations, they require that our rebates, and I'll talk about the rebate dynamic, but our rebates have to be prioritized to supporting these ADAP services. And so that'll be a theme that comes up. I've shown this slide previously, but this is just a depiction of what's happened with Ryan White resources over the last 5 grant years. Grant year runs from April 1st to March 30th in this program. But you see from grant year 21 all the way to grant year 23, we see it was around $82 million in this program. And then by grant year 25, down to $56 million. So right there, you can see a significant difference, even from grant year 24 to 25, an $11 million decrease. But a couple of things that I want to pull your attention to. The dark blue are grants specifically, and those are relatively stable. You see from 26 million up to 29 million in grant year 25. The grant carryover, of course, that's the light blue, decreased heading into grant year 25. But the rebates are really a big part of the conversation. The rebates went from up to 32 to 33 million in grant years 22 and 23, down to 16 million in grant year 24, and then to 24 million in grant year 25. But that's significant variation there. You also see the big change in rebate carryover as well. So the decrease in the rebate funding, really noticeable and impactful in this program. So in prior grant years, our rebate revenue was inadvertently credited to VDH at higher levels than warranted, and that was due to an error in the claim submission processes. And this ultimately contributed to a reduction in the overall available rebate dollars as compared to previous years, and you saw on the previous slide. And so there's the potential need to repay these rebates. Again, these are voluntary rebates from the manufacturer, so the potential need to repay those to the manufacturer, which will continue to impact upcoming grant years. For this year, for grant year 25, the reduction in available resources, it led to necessary cuts in Part B service funding. That's both internal and external. I'll talk about that a little bit more in a second. So, again, for Part B or for Ryan White Part B grant recipients, we have to assure that our ability to maintain core services and also those resources have to be prioritized for that ADAP as well. So when we're talking about grant year 25, there are a couple of things we did to respond to these dynamics in terms of the finances. The first is we had to reduce the number of Ryan White Part B direct service providers. That's down from 27 to 14, so a significant decrease. And then additionally, we decreased the funding to those remaining providers. So for the 14, they actually got smaller subawards than previous. We also had to reduce the number of services down from 21 to 7. So we eliminated use of Ryan White funds for various programs like the Charlie program or comprehensive HIV/AIDS resources and linkages for individuals experiencing incarceration, status neutral services, trauma-informed health center approaches. Those are different. That's a pilot. So those programs lost that funding, unfortunately. And we had to reduce and modify our internal operations as well. So we eliminated support for staffing positions in HIV prevention, HIV surveillance, and disease intervention specialists. Again, none of this is ideal. None of this is what we want to see for this program in terms of meeting the needs of this population. But one of the requirements, especially from a federal standpoint, is that we have to be really excellent stewards of this program, particularly as it pertains to the drug assistance and the insurance piece as well. So that's one of the things we're aiming to do. I want to take a second and also just mention the broader landscape here. Across the country, we've seen challenges that states are facing in terms of funding Ryan White Part B, and in particular, the ADAP funding. That has been flat funded since 2014 federally. And what that means is that in terms of inflation-adjusted dollars, that's a 31% decrease in funding over the last 20 years. So this is a program that even though federally we're seeing lots of dollars, we're seeing that a lot of states are facing real challenges with this program. At present, about 23 states are talking about how they're changing services in their Ryan White program. They're either changing who's eligible and decreasing that those eligibility thresholds. They're changing what is on their formulary in terms of drugs that folks can get, because some of the factors are, again, the cost of medications, the cost of insurance, which we see is going to continue to increase with some of the challenges in terms of subsidies, and then the number of folks enrolled. The good news is, and I say this as an internal medicine doctor, with these medications, folks are living longer lives with HIV. The challenge is that means that, if we look nationally, we're seeing more people who are continuing to support through these kind of programs. So when you put those dynamics together, again, this is something a lot of states are grappling with. In Virginia, we layer on top of that our rebate challenges, and that adds to the dynamic. So in terms of how we responded to this unique challenge here in Virginia, we did a couple of things. The first is we pursued additional funding. So for Ryan White Part B supplemental, we got $3.8 million in additional funding. We also requested funding through ADAP emergency relief funding, and then also additional ADAP supplemental dollars as well. So using every available tool federally to bring in additional dollars for this program. Next, enhancing enrollment and client initiatives. So trying to get our more clients enrolled in Medicaid, maximizing healthcare coverage, outreach, and enrollment. And again, apropos to the conversation we had earlier, the challenges we're seeing in Medicaid are going to have implications for programs like this as well. And then considering options related to premium payments to maximize rebates, and then looking at things like the frequency of client eligibility determinations. From an internal side of things, really trying to strengthen our budget projections in those methodologies, and then enhancing our rebate monitoring and reconciliation processes. Again, continuing to have dialogue with the manufacturer to make sure that we have a really good sense of what can and should be coming our way in terms of rebates. Again, those are voluntary rebates, but we have a process that we want to adhere to. And then the formulary management options. I mentioned other states around the country are considering this, so that conversation around formulary reduction or prior authorization. I'll give the example of Biktarvy, which is the medication for HIV that's most frequently used. It's a single pill a day. We know that increases adherence. It's also extremely expensive. And so for medications like Biktarvy, some states Florida actually recently considered pulling Biktarvy from their formulary. And that has huge impact. And even the two drug regimens, again, far more expensive than the medications we've had in the past. So things for us to think about, and again, it's our responsibility to be really good stewards of the program. And so those aren't specific considerations we've had here in Virginia, just giving you a sense of the federal conversation, but we're going to talk about what formulary management looks like here in the Commonwealth and continue to engage with our stakeholders so we can do this well and still try to provide optimal services. Just a couple more in terms of data on the estimated budget need. I really want to draw your attention. In terms of subrecipients, those are key entities here in providing the services to our HIV, our patients who have HIV. So, in terms of resources, we know that about $8.3 million there that we have for subrecipient grants. We expect the expenditures to exceed that by almost $500,000. This is paid for it is the entirety of our base grant for Part B is going towards subrecipients. The important thing to keep in mind, and as I draw your attention to ADAP, you see the grant itself fully exhausted at just over $22.2 million. The rebates that we get from the manufacturer are how we really meet the mail with ADAP. I already described this as a national dynamic where you have states that are stressed to fund their ADAP programs. It's our task to make sure that we are really trying to make sure people have their medications covered and have insurance coverage. A little bit more in terms of history, in the early 2000s, it was commonplace for states to have wait lists for these programs. By 2013, we were able to clear the wait list, and no state has had a wait list since then. The reality is if we can't meet the responsibility in terms of meeting the need and expenditures in ADAP, that is the eventuality, is that we have to decide who gets access and who doesn't. And currently, there are 3 other states that are talking about exploring the idea of wait lists. Again, federal dynamic, we are trying everything we can, and we appreciate you all's help in stabilizing this so that we don't have that dynamic here in Virginia. But you can see in terms of the expenditures for ADAP, it's a gap of almost $6 million there. And that's significant. And I think that's what we're trying to fill here because, again, we want to continue to get medications, continue to get coverage to these patients as the first priority. The subrecipients, I might also add, the funds that they received in addition to the Part B base, that came from the rebates, right? So when our rebates are entirely exhausted trying to pay for ADAP, we don't have those additional funds to give to subrecipients. If, for instance, we took additional funds and just gave those to subrecipients instead, it doesn't address the shortfall in ADAP. And so our challenge is still going to be, we would still have to have those tough conversations about, do we have wait lists and who's covered? So this is all a part of a broader ecosystem. And so that's why we're trying to work really thoughtfully with all parties involved, recognizing the financial realities, but also trying to be good stewards of the resources we have to meet those primary needs, medications, and making sure that folks stay covered. That coverage is also really important for those subrecipients, right? Because they can bill if people are covered. So a couple of things I'll add. So ADAP provides insurance costs or directly provided medications. So of course, health insurance is a more cost-effective option. You guys understand, of course, some of the health insurance challenges that we're facing. Those rebates are generated when ADAP pays for the client's share of cost of medication covered by health insurance. And then those dollars are invested back into Ryan White program to ensure stability. Other things, if you think about kind of federal landscape, Inflation Reduction Act, that had an impact on Part D of Medicare, and so it sets an out-of-pocket cap. Well, that means there are less rebates for our Medicare Part D patients because, again, there's a cap on medications, so we pay less. So, again, that changes the rebate dynamic a little bit as well. And what we know is that Ryan White clients who have health insurance have better outcomes. So, again, critical priority, keep people covered. And then when service providers provide medical care to insured clients, they generate revenue from it. So looking at the year ahead, I've described a lot of challenges, and I'm aware of that. And that's something that we spend every day really thinking about how we can do this well for this critical priority. I want to be clear, the challenges aren't over in terms of what's facing this program. If you look at grant year 26, we anticipate a budget shortfall. And again, we're anticipating starting with a partial federal award. That was one of the challenges we had last year, where we started with the partial federal award. We didn't know if and when we were going to get the full federal award. And we have a similar dynamic this year as well. So again, a lot of factors playing in. Most recent open enrollment period, we've talked nationally about the impact on open enrollment of the cost of insurance this year. VDH enrolled 930 clients into ACA plans, 440 clients into Medicare plans. We expect higher insurance premiums, 20% increase. That's cost to the program. And then there's uncertainty about decreases in federal funding more broadly for HIV prevention and care services. So those funding challenges in the next grant year, they could result in us considering, reconsidering how we approach eligibility, strategic adjustments to subrecipients and services to optimize that network of care. And again, that idea of a client wait list, again, that's a last resort. None of these are things that we want to do. And this is where I just have to say this body has been so thoughtful about how can we add resources into this program. Not every state is having those conversations, and agencies like ours are being forced to make those hard decisions. So we appreciate you all in being thoughtful partners. The last thing I'll share is a commitment to action. And just in terms of how we're approaching this program, I want to be clear. This has my full attention as commissioner and the full attention of my team and the leadership of our teams. As we think about the short term, the next 30 days, we're talking about how we address the rebates with the manufacturer. Those are ongoing conversations, finalizing details of that repayment plan. We're deploying those emergency relief funds. We're meeting with service providers on resources to support clients. Again, I think that transparency and that dialogue is going to be the key, and that's something we really want to continue to strengthen because we're going to have to find the way forward in some difficult waters, but I think we can do that best in collaboration. And then immediate implementation of internal corrective actions. Again, what can we do to fine-tune the program from within? In the next 3 to 6 months, we want to strengthen our rebate claim controls. We want to expand communication with providers. Again, we have a lot of work to do to restore confidence. I think some of that was born in a lack of communication, and we want to do better. And then partnership with legislative stakeholders, again, to address ongoing needs and awareness. Long term, modernize our data systems and internal controls. We want to report quarterly on the status of Ryan White funding, and then strategic planning with advocacy partners to build a more resilient infrastructure. So, and with that, I'll take any questions you have on Ryan White.
Cameron, thank you so much. Another just critical issue, and I really appreciate what you and your team have done to jump on this one as well. You hit the nail right in the head in one of your earlier comments that there's no these patients don't have another option. I mean, this is it. If they're not getting care through this program, they're not getting care. And so it is critical. And I cringed when you talked about what other states are looking at with the wait list. We don't want to go there. Yeah. So we're going to do our best to avoid that. But we do have a question from Delegate Henson.
Thank you, Mr. Chair. I just want to, I guess it's kudos for you and your team today. I do want to give you kudos for bringing this particular program to the forefront because this wasn't a program that I was tracking. But from the former chair, now Secretary of Finance and others, I know I did put in a budget amendment that, Mr. Chair, that you are fighting for on the 12th floor, and it's in the budget. But it was to provide $6.6 million to this particular program because of the concerns that you have outlined here. So this is something that I will be paying attention to, and other states have already contacted me trying to figure out how is the Commonwealth going to respond to that. So just knowing that this is at the forefront of you, Commissioner, and your team, that is very vital and important to me.
Absolutely. Thank you.
Thank you. No, we're talking, and that's the most important thing here. And I think there was, unfortunately, a lack of awareness. I didn't find out about the deficiency until I was hearing from free clinics who were providing those services, and they were losing their funding. But we're past that now, and I think we've got a great dialogue going. We have challenges before us, but we're going to be talking it through, and we're going to do our best on the budget side to make up that deficit there. Well, I really appreciate your time today. This will not be the last conversation we have, but you've been great to share your thoughts today, and good luck to you. And again, let's keep talking.
Absolutely. Thanks so much, Al.
Ladies and gentlemen, with that, we are adjourned. Thank you.